To the September Scotland ITP patient support meeting, which is as always virtual these days. I'd like to welcome our expert clinician, Dr. Catherine Bagot from Glasgow Royal Infirmary, who's joined us today to answer any of your questions. And assisting me as well, I've got patient mentor Rhonda Anderson also with me. And it's good to see a couple of old faces here, but it looks like we've got a few new faces as well. So welcome everyone, and nice to see you all. If you've got any questions, just feel free to ask your questions and we'll try and answer. Okay, so does anyone want to kick off with a question first of all? No?
Well, I'll start off because I mean it's coming up now, isn't it? Flu and COVID vaccinations,
Yes, yes.
and perhaps Catherine can give us a few little clues about that on what to do and what we might expect.
Sure, absolutely. So we had to give this a lot of thought 3 years ago, 4 years ago, when the vaccines came out, because you may know, or you may even be someone who was affected by having a vaccine, any vaccine, not just COVID, and either developing ITP or seeing a worsening of your ITP. So there was a great deal of concern, we need to protect ourselves against COVID and flu, but will it make my ITP worse? So the other side of that is that having flu or having COVID could also trigger your ITP. I've seen both. So it was agreed. So we have something called the UK ITP Forum, which the Patients Association supports, which is a group of clinicians around the UK, and we all sort of got together. Sort of, I don't know, it must have been probably January 2021 when the vaccine was on its way out. Sort of say, okay, how do we handle this? And our recommendation was that we do recommend to patients that you do have your vaccines, COVID, flu, anything else that you are recommended to have. If at the time you've actually got, active ITP, that we do have some patients who, have a low platelet count and don't respond to any treatment, but, still need their vaccinations. So our recommendations were that if your platelet count is more than 10, you don't have to worry about any bleeding from the site of the vaccination at all. But if it's less than 10, you could be at increased risk of bruising from the vaccination. And everyone was recommended to press on the area gently for maybe a minute or so, just to prevent any bruising from happening. Because platelets are responsible for preventing you from bleeding, but so also are our clotting factor proteins. The platelets are something that works straight away, and then the clotting proteins take effect. So if you're going to bleed because of your ITP from injection, you're going to bleed quickly. And so by pressing for a couple of minutes, if you haven't bled by then, you're not going to bleed. The only people that we recommend do not get vaccinated, and this is very much on a case-by-case basis, is I now have a very, very small number of patients, a very small number, who have had at least one relapse in association with the vaccine. And after one of those relapses, it's been very, very difficult to treat. And you discuss this with the patient and explain, okay, we run the risk that if we give you the vaccine again, you could have ITP relapse that we cannot treat. And therefore, on balance, probably it's best not to get the vaccine, but those are really, really few and far between. So overall message is, please get your vaccines. It's obviously your choice, but I strongly recommend them. If your platelet count is very low at the time, then apply pressure for a couple of minutes. And if you've had terrible, terrible untreatable relapses from a vaccine in the past, then probably best not to get that particular type of vaccine, and other vaccines can be discussed with your hematologist. I hope that helps. So go get your vaccines.
Any questions on that? Are you all in favour of that? Yeah? It's a few shaking it, a few nods.
It's a bit scary. I think, if my ITP had been triggered by a vaccine, I'd be like really hesitant. But it's just, if it gets triggered by a vaccine, it could just as much get triggered by the virus. And if you have a really bad virus and it triggers your ITP, you could be really ill from the virus and then be more risk of bleeding. So it's sort of balance of risks and benefits, and you can always talk to your doctor about it.
I know, during, like, when the vaccines first rolled out during COVID, and since that, there was lots of people coming forward saying that their ITP was triggered by the vaccine, but lots of them, when they analysed it, they suddenly presented with ITP some months after
Mm.
having the vaccine, which,
Yeah.
would that rule it out?
Yeah, I mean, so basically what excuse me, happens, and the hypothesis with ITP is that you're exposed to something. We may never know what it is, or it could be a virus, or it could be a vaccine, but you're exposed to something, and your body responds to that something with an immune reaction, which is appropriate if it's a virus or a vaccine, but then you then have an immune reaction to your platelets. So that's the sort of hypothesis behind this. So it's very difficult to say exactly when that response would happen, but generally you would expect that response to happen quite quickly. So people who present with ITP because they've had a vaccine or ITP because they've had a virus, generally it happens within a few days, a couple of weeks. It's not something that happens 3 or 4 months later. That's probably due to a different trigger that we just haven't been able to identify. Now, we don't know precisely, but generally, if someone's going to have an immune response, they have it pretty fast
Yeah,
to
yeah,
the
yeah.
virus or the vaccine, and it'll be this similar with ITP.
Okay. Is there anyone on the call who possibly had issues with the vaccine? When they had it? Sharon, you're shaking your head. Can you, just let us know what happened? You're muted. You don't want to say. Okay, okay. Anyone else? No? Mary, do you want to? We can't hear you, Mary.
Okay, no, it's coming.
You know, no,
Yeah, it's just quiet. We can hear you.
We can hear you. Go on.
I was just going to say, I actually thought, retrospectively, mine was only diagnosed earlier this year, that COVID may have caused it, but I already had SLE, and I started off with tachycardia, was the only thing with COVID. But if it wasn't diagnosed till later, then it wouldn't be connected to the COVID then. If there was a gap of a year, 2 years between.
Yeah, so yeah, I mean it's unlikely. The problem with COVID now is that people can get COVID and not know they've got COVID, so it can be difficult to know did COVID trigger it or not. But if you had COVID and then a year or so later you got ITP, and particularly if you've got another risk factor ITP, SLE, then I'd say it's much, much more likely to be the SLE than it is COVID. Yeah.
Okay, thank you, Mary. What I will do when I post the video to this tomorrow, I will put the links on the comments on the video of vaccine page, etc., and any other information. So you've got all that as well. I just want to ask a quick question as well, Catherine, whilst you're on, that there's quite a few clinical trials now underway
There are
in the
indeed.
UK.
There are
I
indeed.
believe there are some at Glasgow Royal Infirmary. You just want to
Yes,
let people know
yes.
if you can.
So we're really lucky in Glasgow that we're able to run these clinical trials, and we have two running at the moment. Well, actually, I suppose we have two running at the moment, and they all have the most ridiculous names you've ever heard of. So I can start with the first one, that's called Efgartigimod. I've
Yes.
spent a long time practicing that, so
I still can't say it. I still
yeah,
can't say it.
call it the EFA trial if you want. So this is a clever little molecule. We all make antibodies as we should, and these antibodies are constantly circling through cells. And when they circle through cells, there's a little receptor inside the cell that says, oh, and sort of protects it so that it's thrown back out again. So what this drug does is it binds to this particular receptor so that when the antibodies are going through these cells, they're no longer protected by the receptor and they get killed by the cell. So the theory being is that you are reducing your number of antibodies and therefore you're reducing your response to your platelets. So the interesting thing about that drug is it's gone through a lot of clinical trials in Japan, and it actually has a license in Japan for ITP, which is interesting that we're still going through trials here in this country. But it seems to be, as running a trial, you don't have data that's absolutely up to date as of like the summer of 2025. So I think the most up to date data I have now for efgartigimod probably is like the end of 2023, beginning of 2024. And at that stage, something like 100 patients around the world in clinical trials have been treated with efgartigimod, and there's been about a 25% response. Now, the people that you may think, oh, that's not very good. The people who go into clinical trials generally have very severe ITP. They've received their avatrombopag and their romiplostim, and they've probably been on mycophenolate, all these different drugs. They might have even had their spleen taken out. And so these people are generally very resistant to treatment. So I have to say a response for about 25% is not entirely unexpected. And that's only in 100 patients. There's been 3,000 patients around the world that have been exposed to efgartigimod, not necessarily just for ITP. And the safety profile seems to be very, very good. It's given as an injection into a vein, so similar to your rituximab sort of things. And it can be given once a week or once every other week, depending on how well your platelets are responding. So that's that study. And then the other study, another very interesting word, mezagitamab. Again, I've practiced that a lot. That is so for any of you who know about rituximab, but I appreciate some of you may not. So just going back another stage. So one of the big features of ITP is that you make antibodies against your platelets. We all have cells within us called lymphocytes, and these are the cells that are responsible for making antibodies. Now, rituximab is a drug that attacks those lymphocytes and stops you from making so many antibodies. But this drug, mezagitamab, goes back a little bit further and destroys lymphocytes that are a bit less mature. They're called plasma cells. And so basically what this drug is trying to do is sort of hit these lymphocytes a bit earlier. And with the hypothesis bit, with the theory being that perhaps if you hit these cells early in their development, you might have more effective treatment. This does not have a license anywhere in the world yet for ITP. So it hasn't been, not as many people have been exposed to it. And again, my data is not completely up to date. Again, I probably have data to the end of 2023, beginning of 2024. So although we've got quite a lot of data accumulating that it's safe, we don't yet know what its effectiveness level is in ITP. Now, it may be that we're going to find that out very soon, but it's very, very early days. This is an injection given under the skin. So if anyone is on romiplostim, it's like what we call a subcutaneous injection, and it's given weekly for 8 weeks. Then you have 8 weeks off, and then you have 8 weeks on. This may sound really, really weird, but it's what they know from the way the drug works and how long it's in the body, and you don't necessarily have to know whether it brings someone platelet count up to know how often to give it. You can look at other markers in the blood that tell you what the best regime of treatment is in terms of how often you need to give it and whether you can give it as an injection and how often you need to give it. So that's a nutshell. Yeah, efgartigimod into a vein stops your antibodies from cycling. Mezagitamab, little injection under the skin once a week. That affects the way your less mature lymphocytes work. Any questions? Oh, sorry, that's so
Questions on that?
Little lesson in biology.
Yeah. I know there's also been a few trials that have finished, and we're waiting for the results.
Yeah, sorry, I didn't talk about those because I thought because they're not available.
I know one of them I've been told. Lanamanabab, is it?
Ianalimab's closed, you see. So
yeah,
I didn't
closed.
talk about that.
And I've been told by the good sources we should get the information in time for ASH.
Yes, I'm sure we will. I'm
Yeah,
sure.
so it's,
Yeah.
it's going to be announced then what the results are, which I don't know. I
Yeah.
don't
Just,
know.
I mean, for people's interest, just to let you, so the thing that's really, really nice about ITP is that things have changed so much over the last 10 to 15 years, massively so. And, when I first became a consultant hematologist, we didn't have avatrombopag and romiplostim and eltrombopag. We didn't have those drugs at all. And they were the first drugs that had gone through proper clinical trials. And, they don't suppress the immune system. And it's through all people like yourselves who go into trials, over the years that have allowed us to develop these new drugs. So I'm very passionate about clinical trials. It's a huge ask for a patient, but it's the way we move things forward. And you always hope in a clinical trial that the actual patient who's been so kind and thoughtful and have put themselves forward for the trial, not only is contributing to the health of ITP patients in the future, but is also hopefully going to get a benefit themselves. But, running clinical trials, I always say to a patient, you may not respond to this drug. And the other thing I should have mentioned is that all the two trials I just mentioned are placebo controlled. So that means you won't necessarily get the drug, although you will eventually. So all these trials, you have to do that. Otherwise, you don't know whether the patient's ITP could have just got better by itself. So they always do it so that you're more likely to get the drug than not. So it's what we call 2 to 1. So for every 3 patients, 2 will get the drug, 1 won't. Um, and if you'll never know if you got the placebo, the non-active drug. Um, but if you haven't responded by the end of, the double-blinded bit when no one knows what's going on, you will then get the drug. So, but sometimes that can be a long time. So for the efgartigimod trial, you have to wait nearly 6 months before you are guaranteed. I apologize for that. That's my cat. Um, if you, I don't know if maybe you can't hear it, which is great, but I can hear it. Um, so for the efgartigimod trial, it's about 6 months before you're guaranteed to get the drug. And with the mezagitamab trial, we're just going through some change at the moment. At the moment, it's nearly 6 months, but we're looking to make that much, much shorter before you get the active drug. So yes.
Okay, is there anyone here on the call who's actually ever been involved in a clinical trial? No?
It's a big undertaking.
It is a
One thing
huge undertaking, isn't it? Yeah.
Huge undertaking. One thing I will tell you, it's a bit like if any of you have ever given blood in the past, you're treated like a king or a queen. Everyone thinks you're absolutely amazing giving up all this time. They feed you biscuits and sandwiches and it's known actually that patients that go into clinical trials on average get the best care. And I don't just mean in terms of that nursing and doctoring care, but obviously getting exposed to new treatments, which may be more effective than the things they've been exposed to already. But, the trials I've been talking about, you would basically be coming to Glasgow once a week for 6 months. So it's a huge ask. And I have had patients referred to me who come from outside the Glasgow area. And I suspect they're very interested in the trial, but they realize that it's just such a massive commitment. So I mean, if any of you ever consider trials in the future, not only do you get to meet with someone like me and I go through all the like pros and cons and tell you some of the stuff that I've just told you now, but you get a very large patient information leaflet, which you go away and read about all the pros and cons and what we know so far. So you never rush to get into a trial. And once you've read the patient information leaflet, you can come back and have your questions answered. So there's no rush.
Okay.
So yeah.
Okay, thanks, Catherine. Another question from me. I'm not sure if we're allowed to say anything yet, but there is one of the main treatments that's due to come off patent shortly. Are we allowed to mention that yet?
Um, um,
As long as we don't mention the price, I think we'd be all right.
okay. I mean, maybe you know better than I do. So there's absolutely no, yeah, we definitely can't mention the price. We definitely can't mention
Mention
the
the
price.
price.
So L Trombopag, is so if you've L-trombopag is otherwise known as Revalade. You may recognize the brand name or you may recognize the generic name, but L-trombopag is coming off patent. So L-trombopag, wasn't quite the first to come out actually, but it was about 2012 anyway. And I think patents vary a little bit, but I presume it's about 12 years, the patent.
Mm.
And so that means that once the patent's over, any company can make L-Trombopag. And that's what's happened. And I don't think we're almost there in Scotland. We've almost got the setup where we will be able to prescribe what's called generic L-Trombopag, whereas up until now we've had to prescribe Revolade. And although I can't talk about the prices, the savings, if
Huge.
we prescribe
Yeah.
generic L-Trombopag as opposed to Revolade, would blow your mind, basically. The saving is enormous, absolutely enormous. And L-Trombopag generic is just as effective as Revolade.
Exactly the
There's
same.
no
isn't it?
difference. They're
Exactly the same.
exactly the
Yeah.
same drug.
Yeah.
So if you're on L-Trombopag, you will be asked at some point in the future to move to generic. Please don't worry about that. It is exactly the same thing. It will come with exactly the same diet restrictions and yeah, it will be just as effective. So please feel
There is
reassured
just
about
one bit that's not going to be the same if you have to have the liquid form, isn't
that.
it?
Oh, thank you for reminding me about that. If you're on the
Yeah.
liquid form, that is not coming off patent. So, I mean, I realise it's mainly children that are on the liquid
Yeah.
form, but adults could be on it. That will not change at all. Thank you, Mervyn.
That's okay. That's okay. Yeah. And I believe in England and Wales, I believe it's from October, but I'm not quite sure what the dates are.
We're very close behind. We're
Yeah.
very, very close behind.
I had a meeting with NHS Pharmacy last week about it. So yeah,
Yeah.
just before Quinton. So yeah, so that's good.
So I think the thing to reassure you, again, none of this is official yet, but this is what I'd want to do as a doctor anyway, so I don't mind saying it. Is if you are currently not on L-Trombopag and you need a treatment like L-Trombopag, then we are going to recommend L-Trombopag first because it is so astonishingly cheaper that it would be a little bit, seeing as none of these drugs, avatrombopag, L-Trombopag, or romiplostim, are known to be more effective one than the other. We really are beholden as doctors to say, well, we need to try L-Trombopag first. And if it doesn't work, then of course you will go on to a different drug such as avatrombopag or romiplostim. But I think it would be not appropriate not to recommend it first. However, if you're already on avatrombopag or you're already on romiplostim and it is working, we will not switch you. I suppose I'm about to say I will not switch you, but that will almost certainly be just to reassure everyone. We'd never do that because people, ITP is a very delicate disease, and I'd never want to rock the boat in any patient who's responding to treatment. And I don't think any other Scottish doctor around the country would change you. And although I can't guarantee that until there's official guidance, I'm hoping that will be the case.
Okay, it's enough from me, I think, at the moment. Any questions from anyone? Pat, you're on mute there.
I know she's talking about Revolade, but I had the most terrible, severe reaction after I've been on it 2 years.
Oh, wow.
Terrible.
May I ask what it was, or would you rather not?
Yeah, I suddenly, and my platelets suddenly went up to 360, and they've always been about 98. And I've been taking Revolade, a couple of years, so they came up, to 98 from 60 or 40. But then I suddenly started getting the most terrible pain. First of all, and it's worse at night. Hello? Are you there?
Yeah, go on.
Oh, yeah. It was worse at night. And then I had this severe pain, maybe in my arm and hand. And then the next day that would go away. Then I'd have it like in the leg. And then I couldn't walk properly. And it kept jumping. This went on for, 6 weeks. And I had a hard time for telling the hematologist, could it be this? He said, oh, I don't care about your pain as long as your platelets are okay.
Oops.
But my family doctor said that she felt like it was because it was a side effect. And then eventually I went to the main physician and he said, take her off immediately. So it took time, but it gradually got better over the next couple of months. But the pain was, I've never had such a pain in my life like what I had. It wasn't ordinary pain, like muscle pain or something. I mean, I couldn't even put my hands on the toilet to sit down. It was worse at night, actually. That 8 o'clock would come, and then it really was nasty. I mean, I almost felt suicidal. But anyway, I don't have it now because we got off of it.
Yeah, I mean it's the thing with side effects from drugs, you can never know if it's causing it or not. And so it's always this balance of risks and benefits. So, if you had the most uncontrolled ITP ever, unless you took Revelade, then there needs to be a discussion about balancing the terrible pain you're in versus you bleeding from your ITP. But if your ITP, there was the room to say, okay, well, let's see if your pain gets better by trying something else, then that's something I would do, is switch you. It'd be rare that if your pain was that bad, then it would be rare that I wouldn't switch you, even if your ITP was very difficult control. But if you came off Revelade and we tried the other two tupametics, then I would be a bit nervous. But yeah, I've never heard of that before.
Oh,
Wonder if it's like
that's
bone marrow pain is the only thing I could think of. But
very strange. Yeah. I,
yeah, I mean, generally, so there are drugs you can give that stimulate the production of white cells that can cause bone pain. And in adults, the main active parts of bone marrow are in your breastbone and in your hips, and that's generally where you feel the pain, but you're also getting it other places. So the only thing I can think of is bone marrow activity. That's the only thing I can think of. And why it comes
okay.
on 2 years after starting it is strange, but yeah, I'm glad it's gone.
And no pain pill would work on it at all.
Yeah.
They tried all different pain pills, but yeah. So, well, I'm surprised that nobody else has had that. But it was 2 years later,
Yeah.
and why did my platelets suddenly go up to 360 when they were below 100?
Yeah, nothing surprises me in ITP. Nothing. It just, yeah, who knows? Who knows? I mean, one theory could be, when you first started talking about it, is I wondered whether you'd gone into spontaneous remission, and therefore you didn't need the L-Tromopag or its equivalent anymore. But obviously, you must have done. But that would be my first thoughts. If you suddenly went from 90 to 360 and we're getting bone pain, I'd like, maybe you don't need this anymore. So I might have given you a trial off it and seen what would happen generally. So, because that's generally my rule of thumb. If someone has a normal platelet count, or definitely a high platelet count persistently, then the question is whether they've gone in remission. Again, it's a very difficult thing to tell.
Mm.
What did they put you on, Pat, after they took you off it?
He gave me another medicine, but I didn't dare take any medicine because I thought I don't want any more side effects. They
Okay.
gave me prednisone to get on the plane. So I haven't taken anything since, even though I go to Fernhurst and they test me all the time. And what seems like a miracle is that it's staying over 100.
So
Oh,
maybe my theory is right. Maybe you did go into remission.
Yeah,
It's
yeah. So
possible. I mean, that
my
would be my
fingers crossed.
theory. Yeah.
Yeah.
and you've been back to America, have you, since all this?
Yes, yes. And
So,
they
so
put me in
you've flown
hospital.
there and back, and it's been all right, which is good.
Yes,
Brilliant.
yes. They put me in hospital here, but they couldn't find out what was
No,
wrong.
okay.
And the hematologist kept saying he wouldn't believe my pain. He said my platelets are fine, they're 360, which was not what they usually are. So it took, more weeks of pain until somebody woke up to the fact that that was an allergy from the Revelade.
Okay. Yeah, I've never heard of that at all before. So yeah.
Mm.
You're the first, Pat. Must be all this transatlantic flying you're doing that's causing it. So yeah.
Yeah.
Okay. Any other points from anyone? Just want to ask a question. When you go to your consultant, do you try and prepare for your consultation? Like, do you do a list of questions you want to ask, or any?
Yeah.
You do, Pat? Yeah.
Yeah.
Yeah. Anyone else? Mary?
Well, I am at Glasgow Royal and and they've been very good so far because I've been at the day unit. But it's been more about the steroids got the platelets up. But I have a lot of questions, but I've only asked a couple and I've got an appointment this week where I have got a few questions I want to ask, but not too many.
Okay. If you've got any questions, she's here now. You can.
I love a list of questions because I think I'm a doctor, but even I get nervous when I go and see a doctor. So goodness knows what it's like for a patient, who's not a doctor. So it's not that I make lists, but I can tell that I'm nervous when I go to a doctor, and therefore you forget the things you want to ask. And so having a list is brilliant, because particularly if you're newly diagnosed, because you'll be told loads of things. You'll go away, come back a week later, you'll go away and think, oh God, what did they say about this? What did they say about that? And so I'd always say, think of a question, write it down, and we can address it next time. So highly encourage lists, really. Particularly if you're going through tricky treatment decisions, it's really important to make lists, I think. It's not for everyone. I mean, I have to say, I'd say that probably only 20% of people make lists, if that. It's not common, but I'm all for it. I think it's good.
And
Focuses everyone's mind.
the patients and how they feel because I will ask some questions, but I'm in that phase where you don't know when to react. At the moment, my platelets were all right at 117, and I've got a 4-week appointment this time. But you think if I start getting the bruises on my tongue again, that is probably an indication. If I need to eat soft foods because I'm bruising my tongue, that's probably something what you would have to say. Would that be a marker?
Yeah, so one of the things we should be saying to you when you first get diagnosed is if you have any bleeding symptoms in between appointments, I'll generally say if you get the odd bruise, don't panic. But particularly if we use this term wet bleeding, so if you get blood blisters in your mouth, if you get a nosebleed, if you get gum bleeding, then if it's not really, really bad, you can call us the next morning. If it's really bad, a nosebleed that won't stop, then come to A&E. But I think, I'll be honest, I think we're not absolutely perfect at this, but what we try and do is give you the phone number for our secretaries or the day unit. And sometimes I think we do that not quite as quickly as we need to, because everything's going on and we're chatting about everything. And I sometimes find I haven't given the phone number for the first 1 or 2 appointments. So I apologise in advance.
So went to the day unit, I got down into the 20s and I went straight on. I responded well to prednisolone, and I think had it as part of my lupus 30 years ago. They said I had thrombocytopenia. It's just that this had came a bit out of the blue. So I'm on top of most things at the moment. I'm happy enough.
Good.
Thank you very much, Mary. Thank you. Shea, you got a question? Or you can write it in the chat if you don't want to say it, and then I'll ask it. She's saying, this is for you, Catherine. You can't. Is it true you can't take Doptelet while pregnant? If so, why?
Okay, that's a very, very, very good question. So all the drugs of that, what we call the TPO emetics, who stimulate making platelets, that's romiplostim, avatrombopag, L-trombopag, they all cross the placenta because they're small molecules. And it's not that they necessarily cause harm to the baby, but you don't know. Anything that crosses the placenta, you don't know whether it's going to cause harm to the baby or not. And so, like most drug companies, when they make a new drug, no matter what, will say you can't use it in pregnancy. When you know it's a small molecule and it crosses the placenta, then that's even more a no-no. Doesn't necessarily mean it's going to harm the baby, but it's a no-no. So the bottom line is, or the official line is, never use it. However, you've got to balance the risks and the benefits again, and very occasionally, as hematologists, if we've got patients who have really, really tricky ITP and they respond to nothing except one of the two mimetics, then we will use it. There are a handful of published papers of either just single cases or a very small number of cases where we're not seeing bad outcomes. So we'd never use it just routinely, but if we have patients where we'd have to use big doses of steroids, which are terrible in pregnancy, rituximab again suppresses the immune system and can be harmful to the baby. So there are occasions where you've got a lady who's got a platelet count less than 10 throughout the whole pregnancy. That's very dangerous from a bleeding risk. And then we will use the two hermetics, but we don't use them unless we absolutely have to. And it's like so many things in ITP, it's just a balance of risks and benefits. And what we do is that one of the things we've been worried about is if you expose a pregnant lady to one of these drugs, is it going to stimulate the number of platelets the baby makes? And so we always check the platelet count on the baby when they're born to make sure it's not too high. But we rarely do it. We rarely do it. But certainly there's a handful of cases around the country where we've had to do it.
Okay, got a question in the chat from Sharon. She has ITP, got a count of 55, but she's not on any treatment. She's asking, why is that?
So the theory is we've got spare platelets, probably mainly to prevent pregnant women from bleeding to death when they give birth. So a platelet count of greater than 50, you could have major surgery and you wouldn't be at increased risk of bleeding compared to the general population. So as hematologists, we never treat with a platelet count of greater than 50 unless someone was going to have brain surgery, where we like to have them higher than 50 because it's just such a bleeding area. If a platelet count's greater than 30, the chance of having serious spontaneous bleeding is also pretty much zero. So the risk of a spontaneous bleed into the gut or a risk of spontaneous bleed onto the head is essentially zero when your platelet count's greater than 30. However, you couldn't have surgery, and if you got knocked over by a car, you'd be at increased risk of bleeding. So when you're at that level of 25, 30, it can be difficult. But if I have a very fit and healthy young man or woman, and I'm talking sort of, up to the age of 60 when I'm talking young, someone who's completely fit and well, and their platelet count is 25 and they've got no bleeding symptoms whatsoever, then you have to have a talk with the patient about, if I expose you to steroids or other drugs that suppress your immune system, we could end up causing more harm than doing good. And so there has to be a chat about that. Once a platelet count is less than 10 or someone is having bleeding symptoms, particularly if they have bleeding symptoms, then we will generally treat. Having said that, sometimes you will meet patients who have platelet counts of 1 and all they've got is a little bit of bruising. Now, generally what we do there, if it's the first time they present and they've got a platelet count of 1 and they've just got bruising, we would treat because we don't know what the future holds. But if they have become really resistant to treatment and their platelet count's 1 and they've never bled at all apart from your bruise, then you've got to think about, if I just keep exposing this person to all these drugs, I'm actually causing more harm than good. Now, that's not the best situation to be in. We do get nervous about people who walk around platelet counts of 1. These patients are incredibly rare, but we do get worried about a platelet count of 1. But if you've given a patient every single drug there is and nothing works, then it's a balance of risks and benefits. When people get over the age of 60, we get even more worried because we know that bleeding risk only increases as you get older. So generally, as a rule of thumb, if you're bleeding or it's less than 10, we will treat. If it's more than 30, there has to be a real discussion about whether treatment is actually worthwhile. If it's more than 50, we'd never consider treatment unless you're having brain surgery. So 55, that's good. No treatment required.
Okay, happy with that, Sharon?
Yeah, it's just I have 2 appointments. I have one at my local hospital in Barnsley, from where I'm from, and then I have like a DNA genetic one in Sheffield, which I'm due next week. And all this, what you're talking about, I've not been, nothing's been mentioned. I've inherited this from my father, and my younger 2 sisters have got it as well. It goes back 2 generations, but not one doctor has said anything about. Well, I did have a bone marrow test when I was 5, which is 42 years ago, but I'm never in the doctor's room long enough to ask questions. It's like, oh, your bloods are this, your platelets are this, your whatever's this, that, and t'other, and it's like 2 seconds, or see you in a year. But
Okay,
none of them explain anything to me.
okay.
I'm living with this disease, or whatever you want to call it, and I know not about it.
Okay.
Sure.
What you want to do, Sharon?
I get asked. They say, oh, if you're tired, you're anemic, take some lovely iron tablets. Yeah, I take them. The only time I have platelets is when I've had 3 surgeries, well, 4 surgeries. I've had both knees replaced, I've had my right hip replaced, and I had platelets because the main man at the Allenshire said, basically, you've got to have it. And then I had a blood transfusion 18 months ago, which I was allergic to my own blood, which was strange, but nobody tells me anything from the hospital. I'm just walking in like a pup into a cage full of tigers.
Okay,
So,
okay.
I probably was just explain. So you don't inherit ITP. So ITP is something that you're not born with. So you obviously, I don't know the whole situation for yourself, but it sounds from what you're describing as though you were born with your low platelet count, or at least it was diagnosed when very young, and you've got lots of family members who've also got a low platelet count. So
Yeah.
that is almost certainly not ITP. It's a problem with platelets, but it's not ITP. So when you have ITP, you make platelets with no problems at all, but you destroy them too quickly. In your condition, probably you aren't quite making enough platelets, which is why you say you had a bone marrow test when you were 5, because they were trying to find out what was going on in the bone marrow.
No, the bone marrow test was because my younger sister had cancer, and they wanted us all to be tested to see if we could help her.
Ah, right, okay. So, but certainly running through the family, that won't be ITP. This'll be a low platelet count that's running through the family. And there's many reasons for having a low platelet count that runs through the family. So there's 2 things then. One, you have to look at how many platelets you have, but the other thing you have to look at is how well the platelets work. So that's a different situation. So we know patients who have ITP, their platelets won't have no problems at all. They just don't have enough of them. But some of the people who are born with a low platelet count that's running through the family, sometimes it's just that their platelet count is low, and then 55 would be absolutely fine. But sometimes they can have a low platelet count and those platelets don't work perfectly, and therefore their bleeding risk can be higher than you might think from the platelet count. I think what I'd say though, if it's really tricky and you go to these appointments and you feel like you get no chance to ask anything, that's when a list is a really good idea. Just think of your top 3 questions that you really want to know. Maybe the first question would be, what is a safe platelet count for me? And then hopefully they'll explain to you whether they think it's just a low platelet count or whether the platelets also don't work well enough. So I think to really get something out of your consultations, if you're feeling rushed, is to make a list of questions. But I suspect from what you said, you probably don't have ITP. It's a problem with your platelets, but it's just not ITP.
What I've done, Sharon, in the
Sorry.
chat, I've put some links for you. There's one to our shared decision-making document that also, and if you could show that to your consultant, that will guide them through what treatments are available, which they should know. But another one is the discussion guide, which you can print out, and that will guide you through what questions to ask when you go for your consultation. It's a sort of like a mind jogger of, which way to go, with your questioning, which will help greatly. Okay. There's another question here from Liz. In light of recent research showing clopidogrel, is better than aspirin for preventing cardiac events, which one is better for an ITP patient?
Oh,
Another one I can't pronounce.
clopidogrel. So both aspirin and clopidogrel affect platelet function in different ways. And to keep it sort of simple, clopidogrel is sort of a stronger inhibitor of platelets than aspirin. So as the years have gone on, we've just been getting more and more and more evidence that clopidogrel is better than aspirin for heart attacks, strokes, blood clots in the arteries of the legs, loads and loads of things. Now, if I've got an ITP patient this can happen, if you have an ITP patient who has a heart attack or a stroke, then it's a balance of risks and benefits. So again, if the platelet count is greater than 50, they can have whatever is required to treat their heart attack, their stroke, the blood clots in the arteries. It's not a question. Above 30, again, it's about that's when you really sort of have to think about the balance of risks and benefits. Probably clopidogrel's okay above 30. People will be a bit twitched. But to be honest with you, if someone has a platelet count of 35, I'd say, well, look, no one's going to have major serious bleeding with a platelet count of 35 going on clopidogrel. They might maybe experience nosebleeds or gum bleeding or easy bruising, but they're unlikely to have really serious bleeding unless, heaven forbid, they were knocked over by a car or something, when yes, that would be a problem. Less than 30, you start to get a bit twitchy, and then you've got, sorry, I keep using the term twitchy, I apologize. A doctor is getting more concerned about whether there's going to be a problem or not. So I would then be talking to the patient about, okay, your platelet count's 15, you've had a heart attack. It'd be quite unusual, but it's not outside the realms of possibility. Maybe we need to think about using something to bring your platelet count up so that we can give you clopidogrel at the same time. So I would always ITP patients, even if they've got a platelet count of 30 or 25, are actually at increased risk of blood clots compared to the general population. Not so much blood clots such as heart attacks and strokes, but certainly blood clots in the deep veins of the leg or on the lungs. So you can't really say to an ITP patient, oh, your platelets are 5, you're not going to get a blood clot, because it's actually not entirely true. So yeah, if your platelet count's 25 and you just had a heart attack or you just had a stroke, then there'd need to be a discussion about, do we give you a small dose of steroids? Do we give you some, if someone had just had a bad stroke, then I'd be thinking about giving them immunoglobulins, which can bring the platelet count up quite fast, and giving them an antiplatelet agent such as clopidogrel as soon as possible. Sometimes you're in these situations where the bleeding risk is high and someone needs an antiplatelet agent, and you will then perhaps defer to aspirin because it's weaker. But I hope that sort of helps a little bit in terms of what we do. It's always balances risks and benefits, what the patient wants, what the patient's concerned about, and having a conversation about that. But above 30, I've got no concerns whatever. Give the patient what they need.
Liz, do you want any questions on that?
Yeah, no, that's helpful. It's just that, yeah, I'm currently on aspirin with a count, baby aspirin on a count of about 40. That's what's happened after a cardiac event that happened a year ago.
Right.
I had a major operation. So basically, they're saying to me that I should have aspirin because I could risk of clot. If anything, she thinks I might be more of somebody that clots more than somebody that bleeds, because I don't seem to have a bleeding history.
Yeah.
But if I'm on aspirin, it's all risk. If you say it's a weaker, well, I don't know. It's not strong.
I presume you're under a cardiologist.
I am, and this is when you're talking about having lists to come to a hematologist with. If when you're between two consultants and you've been signed off by one and then you've got the other, I feel there's a real gap, and I don't know how you bridge that, especially this new research is showing that I think it's 14% difference that you would have a
Effective, yeah,
reduced risk.
yeah,
I think it's a really tricky area, and I feel really in the middle.
yeah.
I've got great support from both, but I'm just really in the middle. And I think it's something that ITP patients in the future, it's not going to be unlikely that people will need to be on aspirin or clopidogrel if they've had some as we get older. And it's something that's not really very clear
Yeah,
for me. And I have been on dual antiplatelet therapy, but I'm now on just the aspirin because my counts were going around about 40 to 50.
So,
Yeah.
so if you walked in my room tomorrow and said, you know, what should I be on clopidogrel? So I'm a hematologist, so although I'm aware of this new research on clopidogrel, I'm not a cardiologist, so I don't know all the things, don't know everything. So you come into me and say, well, can I take clopidogrel? And I would say from a bleeding risk point of view, I don't actually think it would be that bad to put on clopidogrel. And I would drop a note to your cardiologists and say,
Okay.
had this conversation. What do you think about the new research? Is it beneficial enough that we should put Liz onto clopidogrel? And it's like joint decision making, well, like three-way decision making. I think the clopidogrel is probably the absolute best, but
Okay.
being on aspirin is pretty good.
Yeah.
So, you know, it's about some risk and benefit. I just realised it's completely dark around my head. I just realised
Yes.
the sun has
Something
set during this.
from traitors or something.
So I think either have a chat with your cardiologist and say, well, no, I think say to hematologist, should I be going to clopidogrel? Or you can say you can say to either, should I be going to clopidogrel? Now your cardiologist will look at your platelet count and go, oh my God, you can't possibly be on clopidogrel because it's so low. Whereas your hematologist will go, well, look, I know your platelets are absolutely excellent. So it probably is okay to go on clopidogrel if your cardiologist feels you want it. So it's a bit of a three-way conversation, but you are pretty well protected on aspirin. So
It's a difficult thing for me, actually. But yeah, I could go and ask, but I have been sort of discharged from the cardiologist, so I could actually ask to go and speak to them again. I don't think aspirin's going to be too bad a thing for me, really, to continue with. We'll look at the risks. The only thing is I'm going to fly for the first time next week. And I hope that that's going to be okay, because it'll be the first time I've flown with low platelets and aspirin. I take it I should be okay. Because I think, if anything, she's just guessing maybe I'm a bit more of somebody that tends to because I don't have bleeding issues.
Yeah. So basically, don't worry about flights. Now I can't say anything about heart attacks and cardiac issues, but in terms of your ITP,
exactly.
in terms of your ITP, you can definitely go on a flight.
With the aspirin.
So the aspirin doesn't protect you against blood clots that are deep in your veins, but don't worry about it. So basically, when you're on your flight, are you going for more than 4 hours, or is it shorter?
No, it'll be 3 hours. Yeah.
So that's a very low risk flight anyway. But while you're on the flight, when you're sitting in your seat, flex your ankles backwards and forwards to keep the blood flow going in the legs. Keep well hydrated. The evidence base behind that is we think it gets people to go to the loo more during a flight. And walk around every couple of hours. Because the reason people get blood clots on flights is because they sit in their seat with their legs bent for hours on end.
So I'll continue taking aspirin. I'll go on the flight. But also, I was called for the flu vaccine yesterday, and I decided that I would not take that because I don't know in the next, it was the COVID flu vaccine, and I don't know. I'm going on a flight soon. I thought I can wait till I come back.
Sure, I think, I honestly,
I didn't want to put anything in the mix.
I would do exactly the same.
Okay,
It means you
thanks for
haven't had
that.
the vaccine and you're at risk of flu, but you don't want to spoil your trip away.
But interestingly, when I saw a hematologist, I'm sorry if I'm taking up time here, but I was talking about all the vaccines I needed and I was getting called for, and thinking about what I had been through, and now I'm at a stable count. Of all the vaccines, varicella, pneumococcal, flu, all of that, yes. But there was a bit of a question mark from the haematologist about COVID. And I thought that, I don't know what's changed, but I know that a lot of haematologists are seeing more blood clots since COVID. And I think there's some research going on, but I never knew that. I've always taken the COVID vaccine. So I take it I should take both at the same time when I come back.
Absolutely. I think
Yeah,
so.
thank you.
I was very involved in the whole COVID vaccine issues, both
Okay.
blood clots and low platelets, and
Yeah,
very, very quickly, because I know we're almost at time.
I know, sorry.
It was really tricky with ITP and blood clots and the COVID vaccine, because literally hundreds of thousands of people being vaccinated in a very short space of time, and you know, one in 1,000 has a blood clot, and 1 in 100,000 gets ITP, and so there's going to be a proportion of people who get ITP or a blood clot after they've had their vaccine. So they actually did a big study in Scotland that demonstrated that blood clots were not related to the COVID vaccine. And the similar was shown, not just in Scotland, but similar was shown with the COVID vaccine at ITP. There is a very, very rare condition that affects a very, very small number of the population when exposed to the AstraZeneca COVID vaccine that had a very serious condition, and the AstraZeneca vaccine is not used anymore.
Yeah, because I've always had my vaccines, so I can get both at the same time. And the recommendation was I was to go in and get a blood test maybe the day after or 2 days after to see what my platelet count was. Would you still recommend I do that?
Yeah, we do that. Generally, sometime with about a week, 5 to 7 days, you know, just
5 to 7 days, go and get a platelet count. Just because
you know, your body has an immune reaction to the vaccine, and maybe it's going to have a reaction to your platelets. And generally, unless you're bleeding in the meantime, do it sooner. But yeah,
do it sooner, but get something booked for 5 days. Thanks for clarifying. It was kind of what I thought, but I was a bit thrown with all of that. Thank you very much. Sorry I've taken up that.
All right, I'm just conscious of the time now. There's one more question in the chat from Shire. Has any connection been identified between severe weakness and a disease? Well, it has. Fatigue, you know,
absolutely.
One of the highest low platelet counts are often associated with general body weaknesses. And the key bit there is, and I'm sure you will concur, Catherine, whereas many years ago, many doctors dismissed fatigue as being a symptom. Now it's right up there as one of the top symptoms.
Absolutely.
Good.
Yeah.
And another question Shears asked is, has any connection been identified between the menstrual cycle and the disease? I often feel my platelet levels drop during my period, and we've heard this so often from
So again, I got asked this at the patient meeting in May.
Yes.
I got asked this and I was like, oh. Yeah, I mean, the thing is that ITP is just so it's just so different for every single person. So, you know, I would, you know, if that is happening to a group of people with ITP, that wouldn't surprise me in the slightest, because the body is changing, and then therefore there's, you know, there could be a change how the body's responding to your platelets as well. So,
okay, lovely. Right. Thank you very much, Catherine. And just a reminder, I'll just put it in the chat. We do have session 3 next week of Dr. Andrew Morgan's psychological support sessions for ITP patients. You do need to register. We've had a fantastic turnout for the first 2. Let's hope we get a fantastic turnout for the final one in this series of 3 meetings he's got. But it's all been really well received so far. And coming up the end of the month, I'm doing a patient support day at University Hospitals Coventry and Warwickshire. That's on the 29th. And then on the 29th of October, the following month, we've got the All Ireland ITP patient meeting, again virtual, which will be with one of our patient medical advisors. So thank you very much, Catherine. Thank you for everyone for today. A great meeting, lots of really good questions, and I hope everyone found it useful.
I'm going to go and switch a light on.
Take care, everyone.
Thanks.
I'm trying to find a minute to tell you that.
Thank you so much.
Bye.
Thank you.
Bye-bye.
Bye-bye. Bye.
Thank you.